Examination of the spine. The aim of this video is to introduce students to the examination of the cervical and lumbosacral spine. The objectives are to demonstrate the ability to examine the normal cervical and lumbosacral spine and to describe the surface anatomy of the neck and low back. For examination of the cervical spine, the patient should have his neck and shoulders exposed. As per usual, inspection is performed from the front, sides, and back, focusing on various anatomical landmarks for bone, joints, and muscles around the neck to look for evidence of deformities and muscle wasting. From the sides, pay particular attention to the normal lordotic alignment of the cervical spine. Palpation begins with feeling for temperature using the dorsum of your hand. The most prominent spinous process is that of C7. Palpation for bony tenderness and alignment can begin from above or at the level of C7 itself. Next, palpate for guarding and tenderness of the paravertebral muscles adjacent to the spinous processes. Movements that are possible at the cervical spine are flexion, extension, rotation, and lateral flexion. These are to be assessed actively and passively. Assessment of the low back region requires the whole of the patient's back to be exposed up to the level of the posterior superior iliac spine. Inspection of the back should focus not only on assessment of alignment of the spine to exclude scoliosis, but should also document any asymmetry of skin folds, shoulder height, muscle wasting, or abnormal hair patterns. From the sides, you should note the normal kyphosis of the thoracic spine and lordosis of the lumbar spine. Palpate along the spinous processes for alignment, followed by palpation for tenderness. Palpate the adjacent paravertebral muscles for evidence of tenderness and guarding. Movements of the lumbar spine are flexion, extension, lateral flexion, and rotation. To ensure motion occurs only at the spine, you should be behind the patient and stabilize the patient by placing your hands on the iliac crests and pelvis. By keeping firm control of the patient's pelvis, additional motion at the ilium can be eliminated. Lumbar flexion is measured with Schober's test. A mark is made at the level of the sacroiliac joints or level of the dimples of Venus. Then make another mark 10 centimeters above this first mark. Ask the patient to bend forwards and measure the distance between the two marks. An increase of more than 5 centimeters is normal, and anything less than that indicates limitation of lumbar flexion. Thank your patient when you conclude your examination.